Okay, I'm Bridger Voss, and I'm doing my presentation on electrolytes as it pertains to MLS knowledge. Um, I'll start with a little intro. A table of contents. What I'll be talking about in this presentation is first off the eight major electrolytes. That's sodium through lactate on this list, and then a little bit basic info about them, important info about their regulation, a couple of disease states where you would see increased, decreased values of them, and of course, what method of measurement is used, reference ranges, whatnot. And then I'll also talk about osmolality, the concept of osmolality, and osmolar gap, and then an anion gap, because those are calculations that are directly made off of electrolytes. So if you would be studying electrolytes in sort of a class room setting or whatnot, like they would talk about osmolality and anion gap in the same breath as all of these electrolytes. So starting right off the bat, I'll talk about sodium. Sodium is the most abundant cation in the extracellular fluid. A couple of functions of sodium, as with a lot of these electrolytes, the every single specific function that they have in the body is not completely well known, but we do know a lot of them. And sodium, we know about the sodium potassium pump, seen here on the right, and that pumps exchanges 3 sodium ions for 2 potassium, potassium coming into the cell, sodium exiting the cell. Sodium's because water follows electrolytes across cell membranes. Sodium is used to help maintain the osmotic balance of cells. If they weren't, constantly pumping extra ions out of the cell, then you would have a swelling of cells and then eventually rupturing, and that wouldn't be good. So hypernatremia, low sodium levels. So I'll mention this real quick right now, but with disease states and electrolytes, it's kind of difficult to talk about, especially in a 20-minute presentation. I mean, it would be difficult to really get a good grasp of them in a 5-hour presentation about electrolytes. It's just because electrolytes generally, electrolyte values as they correlate to disease states they're never like the primary, like the cause or whatnot. They're always sort of an additional piece of a diagnosis puzzle when or so like a doctor is diagnosing someone with like a renal failure, and that is the common cause of electrolyte imbalances. And also diagnosing, a certain what sort of level of renal failure there is based on how much of a electrolyte imbalance they have and whatnot. So it's impossible to talk about. There's so many different disease states that you would see an altered electrolyte balance in. So it's impossible to talk about all of them. For all of these electrolytes, I'm just talking about just a couple, usually just like the main ones, the highlights. So with that being said, for sodium, hypernatremia can be caused by increased water retention, as seen in renal failure, kidneys not excreting fluids as they should be. Also, decreased potassium levels. When potassium levels are low, kidneys will end up retaining more sodium in their body to maintain that cation anion balance in the electroneutrality. And then hypernatremia, increased sodium. With values over 160 millimoles per liter, I'll show you the reference range in the next slide. But the upper range is 145 millimoles. So anything above 160 is associated with a mortality rate of 60 to 75%. And something that's very important to highlight about this is the correction of a high or low sodium level must be gradual, maximum of 1 millimole per hour, because any faster correction may cause a cerebral edema. And edema, in general, swelling in different tissues of the body, but a cerebral edema would be the particularly dangerous outcome in there. So specimen type, serum plasma in lithium heparin. Some hemolysis is okay, but a lot of it may cause a false decrease in sodium due to a dilutional effect when all those cells that have inside of them a lower sodium concentration are being lysed. It can dilute the serum or plasma that's being measured. And sodium is measured via ion selective electrode. I won't explain what ion selective electrode is right now because For the next 5, I think it's for the first 5 of these 8 electrolytes, the main method of measurement is ion selector electrode. So I'll wait to explain that until I'm through all the first 5 of these. And then there's a couple of reference ranges. Okay, potassium. Potassium is the major intracellular cation. So you remember the sodium potassium pump? That's pumping potassium into the cell. So that is where the concentration of potassium is. But the potassium, all kinds of functions. One of the main ones is contraction of skeletal cardiac muscles. Regulation of potassium. Proximal tubules will reabsorb all potassium. And then under the influence of aldosterone, the distal tubule and collecting duct will secrete it back into the urine. So that's another common theme with electrolyte imbalances is hormone imbalances, hyperparathyroidism. Anything that would increase the aldosterone in the system would cause a decrease in potassium because the kidney is over excreting that electrolyte. Hypokalemia caused by various things: GI fluid loss, renal failure. Renal failure is on both hyper and hypokalemia. With hypokalemia, it's certain types of renal failure, like renal tubular acidosis. With that acidosis, the extra retention of the hydrogen ions that would promote excretion of more potassium to maintain that electroneutrality. With hyperkalemia, renal failure of just not being able to excrete much in general, you would end up having a buildup of potassium. Concentrations of greater than 10 millimoles may cause cardiac arrest. As we know, potassium is used in muscle contractility. The collection of a potassium sample is important. There are many causes of artifactual hyperkalemia. So coagulation can cause it. False increase. Platelets release potassium when they in the coagulation process. Specimens on ice, cold cells release potassium, and hemolysis being the most important, the most common. With that concentration of potassium inside of the cells, if the cells are lysing, that's releasing all that extra potassium into the serum, falsely increasing it. Plasma, serum, or 24-hour urine specimens can be used, and it is also measured via ion selector electrode, which we'll talk about later, and there's a couple of reference ranges. So chloride. Chloride is the major extracellular anion. So it's out there with sodium, balancing that electroneutrality out in the extracellular fluid. Regulation of chloride. It's initially filtered out by the glomerulus, and then passively reabsorbed with sodium in proximal tubules. And with aldosterone stimulates the kidney to reabsorb more sodium and chloride. So you see it's reabsorbing. Aldosterone causes a reabsorption of sodium and chloride and an excretion of potassium. It's good to know the different hormones and specifically which electrolytes they increase or decrease based on how they promote the retention of it or whatnot. So chloride maintains electroneutrality. You could say actually that it maintains electroneutrality with sodium out there in that extracellular fluid, but also in contrast to bicarbonate. When cell or tissues are respiring, creating that CO2, they will convert, those cells will convert that CO2, some of it at least, into bicarbonate via carbonic anhydrase, that enzyme. And then that bicarbonate will be excreted into the blood, bicarbonate being an important buffering system in the blood. I'll get to that when I talk about bicarbonate here in a sec. And then as those cells are excreting bicarbonate, they're bringing chloride into inside the cells to help maintain that electroneutrality inside the cell. Took a sec. Okay, specimens for chloride: serum, plasma, in lithium heparin. March hemolysis, same as which one was talking about? Sodium? Yeah, sodium. If there's too much hemolysis, it may cause a false decrease due to dilutional effects, all that non-concentrated intracellular fluid being released. Also measured via ion selective electrode, and there's reference ranges. Okay, bicarbonate. So bicarbonate is the second most abundant anion in the extracellular fluid, right after chloride. It is a major buffer component, along with the chloride bicarbonate exchange across cells, but also buffering in blood. It is the alkaline sort of causing molecule, in contrast to carbon dioxide, which would be the acidic causing molecule. Regulation of bicarbonate, proximal distal tubules reabsorb all bicarbonate, and then when there's an excess, they excrete it. So pretty simple with bicarbonate there. Okay, bicarbonate. Um, Metabolic acidosis, respiratory acidosis, and alkalosis, whatnot. Those concepts are important to know for MLT MLS purposes. Bicarbonate is the key molecule when it comes to metabolic acidosis and alkalosis. Bicarbonate is the alkaline sort of producing molecule in the buffer in the blood. So a decrease in um, bicarbonate would cause a decrease in the pH because it's becoming more acidic with less bicarbonate. So that's what metabolic acidosis would be, is a decrease in the bicarbonate. That can cause hyperventilation. That's the body's attempt to decrease the amount of CO2 it has by exhaling more to compensate for that lack in pH, so that decrease in pH, try to bring it back up by getting rid of the acidic component. And then it's just the opposite with metabolic alkalosis. That's caused by an increase in bicarbonate. Both of these are usually caused by types of renal failure. So you have too much bicarbonate, the pH is going up, and it can cause hypoventilation, lack of breathing, to attempt to retain more CO2 to try to bring that pH back down, compensate for it. Specimen type, serum, plasma. This can also be measured, arterial partial CO2 measurements. Based on the lab and different doctoral methods of diagnosing biological processes like metabolic acidosis, total CO2 and bicarbonate can be used interchangeably. So sometimes it's talked like that, but that's why arterial partial CO2 measurements are kind of interchangeable with a bicarbonate measurement. This is also measured via ion selector electrode, and there's a reference range for you. All right, now calcium. Most calcium in the body is found in bones. Of the 1% that's not in bones, that is in the extracellular fluid, 45% of it is termed ionized calcium, and that is just calcium that is free and unbound to proteins or other molecules. So the concentrations of calcium in the blood are 500 to 1,000 times that of cardiac muscle and smooth muscle cells. That is to help maintain a rapid inward flux of calcium during muscle contractility. The regulation of this important hormones, PTH, parathyroid hormone, and vitamin D will cause the kidneys to reabsorb and retain more calcium, and calcitonin does just the opposite. Hypocalcemia, low calcium, can be seen or causing osteodystrophy. Osteodystrophy being a abnormal changes in growth and formation of bones. Also can cause unstable cardiac output, blood pressure. Hypercalcemia, seen in kidney stones. We know that kidney stones are referred to as renal calculi. That cal in there is from the calcium. And the main cause of that is hyperparathyroidism, which causes an increase in parathyroid hormone, which promotes the retention of calcium. Specimen type of calcium, serum, and lithium heparin measured via ion selector electrode, and those are a couple of reference ranges. Sometimes calcium measurements can be different for adolescents and children due to extra bone growth that's going on there. So that's maybe a different set of reference ranges. Okay, now ISE, ion selective electrodes. Now we're through the first 5, I think it's 5 electrolytes that are primarily measured via ion selective electrode in modern labs. I'll explain to you what that means. Ion selective electrode. So a really in-depth explanation of ion selective electrode would be maybe for a chemical electrical engineering class. But for the purposes of this presentation, basically ion selective electrodes is done. They have 2 electrodes that with selectively permeable membranes to different electrolytes and other molecules that you can measure. are placed in solutions. One of them will be placed in a reference solution with a known value, known amount of sodium in it, and the other one will be placed in an unknown solution, aka a patient sample. And then a difference in electrical activity between those two electrodes is equal to the difference in the concentration, so it's equal to the concentration in that patient sample. So that's basically they're just measuring the electrical activity of patient serum, plasma, and urine. So that's the basics of it. On to magnesium, our sixth electrolyte. So magnesium, the second most abundant intracellular cation, and that's after potassium. Potassium would be the first. So most magnesium is found in bone and organs. Of the 1% that's in serum and red blood cells, 61% of that is in the ionized state. So that is unbound, and that is, as labeled here, the physiologically active state. With magnesium, the exact functions of magnesium are not super well known. It's known to be the essential cofactor in 300 plus enzymes. That's the story, like I've said, for a lot of these electrolytes. It's not, we don't exactly know everything that they do in the body, but we know somewhat. But magnesium, so regulation of it. Most of dietary magnesium is absorbed, and then reabsorption in the kidney is done all along the both tubules and in the ascending limb of Henle's loop. So really just not the descending limb of Henle's loop. And then PTH, parathyroid hormone, that's a critical hormone for it. That promotes the retention and more absorption in the intestine of magnesium. Hypermagnesemia. Just as we don't understand super well its processes, we also don't understand it's and it would take a 5-hour presentation to talk about all the different disease states that you'd see a high and low magnesium in. But here, cardiovascular, dermatologic, GI, neurologic, metabolic abnormalities. It's a wide range of disease states that you could see a high or low magnesium value in. Magnesium specimens, serum, lithium, heparin. I probably should have just said serum, lithium, heparin for all of these because that's where it's measured in. I mean, beside the bicarbonate CO2, you can measure partial CO2 on arterial and whole blood specimens. Hemolysis is bad for magnesium because it's an intracellularly concentrated cation electrolyte. So if you have those lysine cells, all that electrolyte is being released, and that's causes a falsely increased magnesium value. So with magnesium and with the other two, so the last three electrolytes, they're all, the primary method of measuring them in modern laboratories is calorimetric. In magnesium's case, calamigite, I hope that's how you pronounce it, that can bind to magnesium, and that will form a spectrophotometrically active complex that can be read at, in this case, 532 nanometers. And that 532 nanometers, that's a wavelength on the visible spectrum. So it's just like a color, basically. And reference range for you. All right, now phosphate. So phosphate is an intracellular anion. I'm done ranking them now. And phosphate's important in many biochemical processes, not the least of which ATP, adenosine triphosphate. We all know ATP, ADP. So that's where you'll find phosphates. And in fact, ADP, so ATP depletion is the ultimately responsible for most clinical symptoms that you see from a hypophosphatemia, whatever the heck you'd say, state, a low phosphate state. And so PTH, parathyroid hormone, decreases, as you see in parathyroid hormone not. It's good to know which electrolytes it increases and decreases, promotes the excretion and retention of. Vitamin D and growth hormone both increase phosphate levels. Hypophosphatemia, just interesting statistics. 60 to 80% of ICU patients with sepsis are in a high hypophosphatemic state. And less than 1 gram per deciliter, I'll show you the reference ranges in later, but is a severe state correlated with a 30% mortality rate. Hyperphosphatemia, associated with renal disease, as is all of these electrolytes, except one. We'll get to that one. Neonates are particularly susceptible because of their undeveloped hormones, PTH and vitamin D. Specimen for phosphate, serum, lithium, heparin, plasma. Also in urine, we can measure that. Hemolysis is bad because it's an intracellular anion electrolyte. Also measured colorimetrically through this is through the formation of an ammonium phosphomolybdate. That is how you pronounce that. A complex which can be read at 34 nanometers on the visible spectrum. There's a couple of reference ranges. All right, now lactate. I think this is the eighth one. This is the last one of the individual electrolytes. Lactate, also known as lactic acid, byproduct of emergency anaerobic glycolysis. When to produce ATP when oxygen delivery is diminished, creating a couple of pyruvates. We all know that process. And then the liver, the one electrolyte that is not primarily regulated by the kidney and hormones, the liver converts lactate back to glucose, removing it from circulation. So, a couple of disease states. They just kind of lactic acidosis. They break it down into type A and type B. Type A is classic hypoxic conditions caused by exercise, but also shock, myocardial infarction, heart attack. And also type B lactic acidosis. That's the more complicated version. That's the metabolic origin. And there's plenty of disease states that you can see that in. Diabetes, leukemia, to name a couple. Okay. Specimen types for lactate, heparin plasma on ice is the preferred. Also measured colorimetrically, enzymatically. Kind of depends on the exact processes of the colorimetric measurement, but ultimately it's colorimetric because you create a spectrophotometrically active compound, and that's done when lactate's being it's through the same process as actually the liver uses to turn lactate back into glucoses through lactate oxidase. That creates hydrogen peroxide. Hydrogen peroxide then reacts with HRP, another compound, to create a spectrophotometrically, I'll get it by the end of this presentation, active compound read at 540, 570 nanometers. And that's the reference range for it. Okay, so that's all of the 8 main electrolytes individually. So now I'll talk about osmolality in general and then anion gap. So osmolality, I wonder what the Google definition is actually of osmolality. But basically, it's the measure of the concentration of dissolved particles in any solution, really, but in your blood. And method that is used to measure this is two things. First of all, you can calculate osmolality, as in demonstrating this equation here. Now, this equation, this is the osmolality equation, and it's there's a couple of different versions of this equation. Some versions, instead of having a 2 multiplied by the sodium and potassium, the cations, it would be 1.8, and then at the end of the equation, they would add 9. They also sometimes will add ethyl alcohol as a part of this. So you see this blood, urea nitrogen, glucose, and then they would also add an ethyl alcohol part of this. Okay, with these calculations, you can also measure osmolality using freezing point depression technology. At least in model labs, what they do. Freezing point solution. So the concept of freezing point depression is basically in a solution, in a liquid, the freezing point of that solution will be lower if there are more particles in it, if there's more solute in there. The more solute, the lower that freezing point will be. So in terms of blood and urine, if there's more electrolytes, more particles in there, if it's more concentrated, that freezing point will be lower. And that difference in the freezing point can be measured and then is correlated with the amount of solute, the amount of particles, electrolytes that are in serum and urine. And it's proportional to that amount. So they will literally take a small amount of sample, freeze it, and measure at what temperature it froze, and then based on a couple of controls, that'll measure how much solute there is, and then they can use a measured value of osmolality with this calculated value to calculate an osmolality gap. So if there's a big gap between measured and then calculated, then that can be indicative of some sort of disease state, some sort of extra electrolyte particle, something in the blood that is causing that. A couple of reference ranges. Okay, now anion gap. Now anion gap, similar concept as osmolality gap. It's the difference between measured cations and anions. As you can see on the right here, this diagram. Generally, the theory is in your blood, there is an electroneutrality there. So you would have the same amount of positively charged particles as you do negatively charged particles. And so just the four that we use to calculate this, sodium, potassium, chloride, and bicarbonate, there's a small anion gap there in unmeasured anions is what they would call it. And that gap has a reference range. So if and this equation is sometimes it's done with potassium or without potassium, because potassium is a small part of it, but they have the different reference ranges there. And if you're answering a question on a MLT exam about this, they will tell you whether to use potassium or not, whether it was used or whether, if you're doing the calculation yourself, whether to use it. These what's commonly seen disease states for an increase in anion gap or a decrease in it is obviously renal failure. But another more interesting one is the ingestion of toxic alcohols. And that's not just ethyl alcohol. That is a common feature, but things like ethylene glycol. Ethylene glycol is what's in antifreeze. So if someone gets accidentally poisoned with antifreeze, they would have an increased anion gap. And okay, that was a presentation. Hope you enjoyed it. All right, now for the cool cat lawbreakers. I cut this slide out of the main presentation because I was trying to cut off time for 20 minutes. I think this is really nice. So osmolality, back to osmolality, concept of osmolality, solutes in solution, particles in your blood. With an increase in osmolality, that means that there's an increase in the concentration of particles in your blood. You'll have an increase in, let's see, what is that? AVP. Oh, yeah, that's right. It says it on there. Dumbass. Arginine vasopressin. So, and arginine vasopressin facilitates water reabsorption by the kidney and the contraction of smooth muscle cells and arteries. So that means if you have a concentrated serum, AVP will be released, and that tells your kidneys to reabsorb more water. So that's to attempt to dilute your serum, and also to contract the muscle cells in arteries. And so that's to generally, if there's an increase in osmolality, that's a more concentration of the serum. That's probably seen in low blood volume, which is down here on the bottom of this slide. And so the blood vessels would want to contract to maintain proper cardiac output and blood pressure. And also it increases thirst. So you'd want it. So you're not just wanting to keep more water in your kidneys, but you want to drink more too. And it's the opposite for a decrease in osmolality. Decrease in osmolality. So if it's more dilute serum, that AVP will go away. So your kidney will be very comfortable excreting more urine, and you won't. And thirst will decrease you, so you won't be thirsty. So then with blood volume with osmolality, so if there's an increase in the blood volume in total, so this is not really a measurement of the solutes. It's just that there's more blood. But this pertains to osmolality sometimes, because if you have a decrease, or sorry, an increase in osmolality, your urine will attempt your kidney will attempt to keep more liquid inside. And just because you have a high osmolality doesn't mean that you just have like low water in your blood. You could be having it could be renal failure. You could have too much electrolytes building up, too much bicarbonate. That's an increase in osmolality. Now your kidneys are trying to retain, because of renal failure, more liquid, and so that increases the blood volume in general. And if you have an increase in blood volume, ANP is atrial natriuretic. That is how you pronounce it. Atrial natriuretic peptide, which will release from the heart, atrial myocardia, I think, and that promotes more sodium excretion. So it's with that, it will attempt to get rid of more electrolytes, decreasing the osmolality. Hopefully, if you have a decrease in osmolality, then you'll have a decrease in the AVP, the arginine vasopressin, which will decrease in AFP. That will tell your kidneys to be comfortable releasing more liquid. So if you have more blood volume, basically it tells your kidneys to hopefully get rid of sodium and get rid of water. Just get rid of all of it. And decrease in blood volume would cause the RAS activation. RAS being renin-angiotensin-aldosterone system. That's a complicated system. You can go look it up yourself if you want. But basics of it is that it increases the vasoconstriction. So you have less blood. The blood vessels, they still need to produce that proper level of blood pressure to get blood to all of your tissues from the heart. So it constricts blood vessels. Also increases aldosterone, which increases the reabsorption of water in the kidney. So it attempts to pump the blood volume back up by holding on to more liquid. Okay, and that's actually the end of this presentation. So thank you.